So the title of the next talk is Fast MR Imaging in the Stroke Patients, Integration into Clinical Decision Making by Dr. Kambith Nail from UCLA here.
Is the mouse? Yeah. So this is the laser pointer. Okay. How do I advance? Is advancing slides? I think so. Okay, great. All right. Good morning, everyone. I'd like to thank the organizers for inviting me to give this talk. Paul Fien, Mahmoud Musabasha, and the rest of the program committee. These are my disclosures. The objectives of this talk is basically to go over quickly the role of MRI for evaluation of patients with acute ischemic stroke, and then we'll focus on how to put together a streamlined and fast MRI workflow for acute ischemic stroke patients. So the major objective of stroke imaging is really to identify patients who can be safely treated. And in order to do that, you need to rule out intracranial hemorrhage. If you are doing it by MR, you basically use a combination of gradient images like GRE and FLAIR to look for intracranial hemorrhage. And that combination has as good, or if not better, accuracy as non-contrast CT for evaluating intracranial hemorrhage. Identifying large vessel occlusion is a major target for treatment, and as a previous speaker talked about, MRA can clearly do this for you. Diffusion imaging to identify early ischemic changes, whether that is subjective or you can actually quantify them by using aspect score on MR or even measuring the volume of infarction, and identifying the tissue at risk, or the so-called penumbra, using perfusion imaging. And that is relatively easy here on MR in comparison to CT, because you don't really need to make any assumptions. You already know what the ischemic core is based on your diffusion imaging, and you use your perfusion imaging Tmax, time to maximum, from DSC perfusion with threshold more than 6 seconds. That has been validated and used for basically a marker of penumbra or tissue at risk. So again, as previous speaker said, basically DWI is really what makes MRI is extremely valuable in evaluating patients with acute ischemic stroke. It's by far the most accurate and sensitive imaging modality we have for evaluating early ischemic changes. As early as 11 minutes from the onset of ischemic stroke, you can actually see diffusion signal change that can go undetected with any other imaging sequences on MR or even obviously on CT. It's an excellent tool for evaluating small infarcts, brainstem infarctions that you cannot see them. And also it is greatly helpful for differentiating stroke mimics. For example, in this case, you see that there is reduced diffusion in the mesiotemporal lobe. I don't know if I can point out to mesiotemporal lobe, hippocampus, and the pulvinar of the thalamus, a combination that can be seen with post-ictal patients in the setting of seizure as opposed to acute infarction. So despite the advantages we discussed, if you look at the randomized clinical trial that they have open arm to enroll both by MR or CT, you see that the minority of patients were enrolled by MRI. The Fuse 3 that was just completed a couple of years ago basically had 25% enrollment. And the reason for this has been discussed in the literature extensively. This is the editorial in AJNR that basically the conclusion is limited access of to MR, disruption, delayed workflow, and longer acquisition times are the major obstacles for broader acceptance of MRI for acute stroke evaluation. But this was followed by another editorial in Neurology, MRI in acute stroke, good times are coming. And they discussed the potential ways to basically improve the acceptance of MR. One would be the access. For example, small footprint MRIs that are now being discussed in the community. Contraindications to MRI are progressively decreasing due to better device design. And for example, stents are more compatible with MR, and therefore a lot of patients would not have contraindication for that. And also improvement in workflow and acquisition, that's where we're going to focus. So a fast MRI for stroke imaging, this was a protocol that we put together almost 8 years ago, and we used it when I was in the University of Arizona in our patients, and now we're using it. I've been in several institutions, and this has been used, and I think a lot of people, if no radiologists in the audience, if they use MR, they probably use a flavor of this fast stroke imaging for their patients. So if you look at it, this is nothing really extremely fancy or extravagant. It's basically using a combination of echoplanar imaging and parallel acquisition to accelerate your existing sequences in order to get this done in about 5 to 6 minutes. And then contrast prepression is basically a standard dose of contrast. You divide that into halves and use 1/2 for contrast-enhanced MRA that is done from aortic arch all the way to the vertex. And then that is followed by MR perfusion for basically evaluating the penumbra. So again, these are the sequence parameters. Again, the main points here is using parallel acquisition and using echoplanar imaging in order to get this done. So before we did this, again, this is just an example of 6-minute stroke protocol using diffusion imaging, EPI flare, EPI gradient, EPI-GRE, MR perfusion, and MRA. In order to do this and basically to establish this, we had to do a few pilot studies that I'm just going to go through them very quickly to show basically the feasibility of EPI flare. Is that comparable to flare? And the same thing for EPI-GRE versus GRE. And then at the end, we had to show whether we could combine contrast-enhanced MRA and DSC perfusion. Because again, as previous speaker said, if you are going to use time-of-flight MRA, that's about 8 to 10 minutes acquisition for both neck and brain. And you can get that done in 20 seconds if you are to use contrast-enhanced MRA. So that's a significant advantage if you can accomplish that in conjunction with DSC perfusion. So to establish the feasibility of EPI flare, we basically looked at a group of patients. We specifically look at the flare signal change in the area of infarction bed. And we have both conventional flare and EPI flare available in these patients. And we basically showed that conventional flare findings were concordant with EPI flare in 29 out of 30 patients, with 2 neuroradiologists blindly reading these studies with an acceptable inter-observer agreement. And then we also did quantitative analysis of the signal intensity ratio of the infarction bed compared to contralateral side, and we showed relatively comparable result between EPI flare and conventional flare. In this patient that I'm showing here, this patient had a coil embolization done. During the procedure, the coil basically migrated and got stuck in the MCA bifurcation and resulted in this right MCA infarct. This was relatively fast, within 1 hour from the onset. And you can see that on both flare and, sorry, this is a little clunky, flare and EPI flare, basically they showed very minimal signal, and the signal intensity ratios were comparable to each other in this patient with hyperacute ischemic stroke. For feasibility of EPI-GRE, again, we looked at a cohort of 50 patients that they have both GRE and EPI-GRE. Again, we showed that they both were able to identify, again, intracranial hemorrhage confirmed on CT, and they both were able to identify clot within the carotid and MCA to the same similar diagnostic performance. And again, these are the examples. The top row is gradient, just conventional images. The bottom is the EPI-GRE. And again, that's another patient with chronic microhemorrhages. And you can see that you can have similar diagnostic performance, image quality in a fraction of time in comparison to conventional GRE imaging. And since you do EPI, you are less sensitive to motion. So in this patient, you can see that flare and EPI flare are shown side by side. Motion is often a problem in stroke patients, and you can see that there is less motion artifact on the EPI flare compared to conventional flare imaging. So the last part, which was the most important part, was to demonstrate the feasibility of combining contrast-enhanced MRA and DSC. I'm showing you here an example of a patient who had basically acute stroke due to carotid terminus occlusion. But also, if you look at the entire supraortic artery, you can see that this patient had a common carotid bifurcation and also a high-grade stenosis at the petrocervical junction. And these are all confirmed on follow-up DSA or catheter angiography. So that's the advantage of having contrast-enhanced MRI over time-of-flight MRI, because you can actually see kind of like the roadmap that you have to go through to get to the occlusion in the brain. And then this needs to be followed by perfusion imaging in order to do a comprehensive stroke protocol. And the question was whether that is feasible. So we looked at two groups of patients. And group one, we accomplished their perfusion just by giving them the full dose of contrast. And the MRA was done with time-of-flight MRA in this cohort. And the second group was patients who received contrast-enhanced MRA, and therefore they received another half of the contrast for their perfusion imaging. And we look at the variety of different variables, including SNR, the maximum T2 signal drop, the background noise, peak of AIF, arterial input function, and the width of AIF. And interestingly, although the maximum signal drop and the peak of AIF were significantly lower in patients with basically half those contrast, you can see that the width of the AIF is not significantly different, and that was what we've shown here. And since the width of AIF is not different, you can assume that the time that it takes to get to the maximum peak, for example, in Tmax or TTP, would not be significantly different. This was evaluated and showed by Jeff Alger group in the publication back in 2009, showing that insignificant effect of contrast dose reduction on time variables. And since in MR, we don't really use CBV or CBF, at least for this purpose of penumbra, and your interest is in time variables, including Tmax, that we use for penumbral imaging. We basically felt that this actually could work, and we could actually combine these MRA and DSC to go ahead and put this protocol together. So this is an example of a 90-year-old woman who presented to ER. Time stroke onset was 70 minutes when the imaging was done. This was a 6-minute stroke protocol, and you can see everything you really need to make decision for treatment is on this slide. Basically, you know that you have LVO, so there's right M1 occlusion. You have small infarction on diffusion imaging. You have no hemorrhage on EPI-GRE or EPI flare here, and you have a large penumbra using Tmax more than 6 seconds. So this patient was taken for thrombectomy, which was successfully accomplished. And then the follow-up MRI, again, another 6 minutes was done to show the successful recanalization. The infarction really didn't change in size. There was a small parenchymal hemorrhage in the opercular region here. You can see on both GRE and flare images. And the penumbra is basically just confined to that region of hemorrhage, but the rest of the penumbra has resolved as a result of revascularization. This is another patient, a 56-year-old woman with left-sided weakness. Again, we have right M1 occlusion. We have relatively small infarction on diffusion images, and we have a large penumbra, and this was successfully recanalized, again, with good resolve for this patient. And this is the last case, a 67-year-old man who presented with aphasia. The 6-minute stroke protocol was performed, showing no evidence of infarct on diffusion images, no large vessel occlusion, and then in the perfusion imaging, we see this regional elevation of Tmax, delayed perfusion in the left parietal and posterior temporal lobe, probably responsible for that aphasia in this patient who had a diagnosis of transient ischemic attack or TIA. So it has been established in the literature that up to 25% of patients with TIA will have abnormal perfusion despite having normal diffusion-weighted imaging. And again, that's another reason to use this comprehensive stroke protocol for all of patients who are presenting with TIA or stroke symptoms in your emergency department. So in summary, MRI is the most sensitive and accurate imaging method in hyperacute stroke. It can improve patient selection and outcome. It can stratify stroke mimics, which are a major challenge, a diagnostic dilemma in the emergency departments. With current state of technology, MRI can rival acquisition times obtained by CT for stroke imaging, and this streamlined MR protocol and pre-imaging algorithms can minimize the time delay that is often associated with MRI as a major obstacle for stroke imaging. And with that, I thank you very much for your attention.